Hi everyone, today we will discuss knee radiography for the radiologist.
My name is Kim McHugh, a technologist.
And my name is Connie Chang and I'm a radiologist. We will review the different projections of the knee, how they're obtained, and what you should look for when you evaluate each view. As a radiologist, it is important that you have a sense of what each view should look like and how they're obtained, because if the view is suboptimal, you may be tricked into calling something pathology that isn't, or you might miss a finding. Also, knowing how to correctly position a patient for your views is very helpful when you are performing fluoroscopically guided procedures.
So the views we will be presenting today are the standard knee projections, which are AP, standing PA flexion, lateral, sunrise, and tunnel.
Before we jump into the views, I just wanted to give a quick introduction on knee arthroplasties because they're so common. On the frontal view, we can see the femoral component and the tibial component, which are radiodense, and the polyethylene spacer, which is radiolucent.
On the frontal view, compare the medial and lateral sides. If one side is too thin, there may be asymmetric wear of that part of the polyethylene spacer. Some femoral components are symmetric, like the ones on the left. Others are not, like the one on the right, and this is important to remember when looking at the femoral component on radiographs. For the prosthesis on the left, we can use the symmetry of the components to help us evaluate whether the knee is rotated. For the prosthesis on the right, we can use the symmetry of the notch. This is what it would look like on a radiograph. Just store this in the back of your mind and we will discuss it in more detail soon. On the lateral view, we can see the tibial and femoral components again, and on this view we can look at the cement bone junction. We can also see the patellofemoral component, which also has a radiolucent spacer.
The spacer can become dislodged and dislocated, so make sure this radiolucent component is in the correct place.
We will begin with the standing AP bilateral knees. The patient stands against the upright image receptor with toes pointing slightly inward and equal weight on both feet. The central ray is directed just below the patella and perpendicular to the image receptor. Both knees are centered to the exposure area and straight without rotation. Notice the patella is in the center of the femur and the tibial spines are symmetric. For the left knee, the prosthesis is symmetric. There is minimal overlap of the fibula behind the tibia. For the PA projection Rosenberg method, the patient stands facing and contacting the detector with the knees flexed approximately 20 to 30 degrees. The X-ray tube is angled 10 degrees caudad, entering at the level of the intercondylar fossa, while the patient holds this squatting position for about 20 seconds.
Have you ever wondered why there are straight and flexion AP views? I'll give you a few moments to think about it. When the knee is straight, the weight-bearing portions of the femoral cartilage and tibial cartilage contact each other. The star indicates the femoral cartilage, which we're going to follow on the next slide. When you bend the knee, the more posterior, non-weight-bearing portion of the femoral cartilage comes in contact with the tibial cartilage. You can see the position of the star on the femur hasn't changed, and it has moved more anterior. So in summary, the flexion view allows us to evaluate the more posterior cartilage of the knee joint. Here's an example of a case where having both views can be helpful. On the MRI, the weight-bearing surface of the femur and the tibia both still have cartilage on them. Therefore, on the AP radiograph with the knee extended, the joint space may actually appear normal. So now let's look at that AP radiograph of the knee, which means that the beam is perpendicular to this sagittal view. So now, with the knee in flexion, the posterior portions of the knee where the cartilage is absent now come in contact with each other. And on the flexion view, now we see that there is complete loss of joint space with bone-on-bone contact. So, to recap, if you see loss of joint space on the standing extended view, the cartilage loss is over the weight-bearing surface. If you see loss of joint space on the flexion view, the cartilage loss is more posterior.
Next is the lateral view. The patient lies on the side being imaged with their knee flexed about 20 to 30 degrees. The other leg is brought up and over to get it out of the way. The tube is angled between 5 and 7 degrees cephalad in order to overlap the femoral condyles because the medial condyle is larger than the lateral condyle. This technique allows us to profile the patella and the patellofemoral joint space. When the patient has a knee replacement, it is important that the posterior portion and femoral pegs of the component are superimposed, as on the left two images. When they are not, the bone cement interface is not visualized. The two images on the left show a perfectly positioned lateral knee. On the two right images, you can see that the prosthesis is not positioned accurately. Neither the posterior portion or the femoral pegs are superimposed, obscuring the bone cement interface. For the sunrise view, the patient holds the cassette and bends their knee until the patella is perpendicular to the imaging plate. The tube angle depends on the patient's anatomy, but is usually anywhere between 0 and 15 degrees. This can be very difficult for the patients to do. On this view, we see the patellofemoral joint space, and the trochlea articular surface. Last is the tunnel view. The patient bends their knee slightly while the cassette is placed underneath and elevated with a positioning aid. The tube is angled approximately 20 degrees cephalad. The tunnel view visualizes the intercondylar fossa along with the tibial spines. You can see avulsion fractures of the tibial spine or intra-articular osteocartilaginous bodies in this region.
Now let's look at some cases. You can pause the video to look at the image and evaluate whether you think the view is adequate or not and why. And then we will review the image. First case. There's too much overlap between the tibia and fibula on both sides. Both knees are externally rotated, but it's worse on the left side. And we can tell that because the notch is not symmetric and the tibial component is not symmetric. So if we were to repeat the view to correct this, we would just internally rotate the knee. Second case. Pretty good. The condyles are superimposed, and the joint space is pretty profiled. We can't see the patellofemoral joint space as well, but that's probably because of the patient's arthritis. Third case. We can see the patellofemoral joint space and the surfaces pretty well, so this looks pretty good to me. Thank you, everyone. We hope this mini lecture was helpful. Bye-bye.
Bye!